mean, the average patient coming to the asthma clinic, you don't say, "Excuse me, madam, can I do a biopsy of your airways?" It just doesn't happen. For getting information about the pathology of the asthma, exhaled nitric oxide is a tool that we can use in that domain. It's not the only tool, but it's a significant tool that we didn't have before. It is important as a marker for what's going on in respect of inflammation. I have two areas in my clinical practice where I find exhaled nitric oxide measurements to be relevant on a day-to-day basis. First, there's dealing with the complex, difficult asthma, particularly if the patient is anxious, particularly if the patient is obese. These are two factors that make the patient say, "My asthma is not good." And previously, we would have written scripts for more and more inhaled steroids, more and more bronchodilators. I have an exhaled nitric oxide level, and if it's low, it means I don't need to worry about airway inflammation, and I don't need to push the dose of inhaled steroids or even the dose of oral steroids any higher. The other important area, and there's a great gap in the literature at the moment, is in dealing with patients who have a chronic cough. If you have a nitric oxide level that's low and the patient has a chronic cough, then you're going to say, well, we're not going to be treating with inhaled steroids, we're going to think about other things that we need to be doing. That's a dimension of things that was unknown to us. We just had to guess. And guesswork is never good in medicine. You don't want your doctor to guess what's going on. You can assess as best he can, and this helps our assessment to be improved and bring up a level.